This is a C. Jason podcast. My name is Daniel Cattran from the University of Toronto. Since the discovery of PLA2R as a putative antigen in approximately 70 to 75% of primary membranous nephropathy, there has been substantial interest in understanding whether antibody levels can be used to monitor disease activity and treatment response. Many studies have looked at anti-PLA2R antibody levels alone over time instead of proteinuria to decide about when to start or stop immunosuppressive treatment. These results, however, have been based on observational data instead of randomized controlled trials. The use of antibody thresholds that are based on characteristics of the assay instead of whether threshold predicts treatment response, or using delayed levels 6 months after treatment. As a result of these limitations, the optimal use of measuring anti-PLA2R antibodies over time as a way of monitoring treatment response has not been clear. My co-author, Sean Barbour, will now explain how we use data from the Mentor trial to evaluate how we can use longitudinal measurements of anti-PLA2R antibody levels, combined with other clinical variables, as a way of predicting response to treatment with either rituximab or cyclosporin.
Thank you, Dan. My name is Sean Barbour from the University of British Columbia. As you recall, the Mentor trial randomized patients with membranous nephropathy to receive either 12 months of cyclosporin or rituximab. In this paper, we included participants in the Mentor trial with positive anti-PLA2R antibody levels at baseline, with antibody levels measured using the Euroimmune assay. The primary aim was to identify as early as possible which participants were going to be resistant to 12 months of treatment by looking at risk factors at baseline and after 3 and 6 months of treatment. Our first step was to look at anti-PLA2R antibody levels at each of these time points as a risk factor for treatment resistance at 12 months. What we found was that at baseline, only very high antibody levels greater than 323 were associated with treatment resistance. But this was very uncommon, and even in those with antibody levels above 323, there were still some patients that responded to treatment. At 3 months, however, there was no specific threshold that best predicted remission status. Instead, it was necessary to consider the change in antibody levels from baseline to 3 months on a continuous scale. What this means is that after 3 months of treatment, it was not an absolute value that best predicted future remission, but instead that every bit of improvement from baseline increased the probability of a subsequent remission. At 6 months, the optimal antibody threshold for treatment resistance was anything greater than 14, which is the same level that determines a positive assay result. We next looked at whether the addition of other clinical variables to PLA2R antibodies could improve our prediction. We found that the best was the combination of the change in PLA2R antibody levels along with the change in serum albumin levels from baseline to 3 months. We also found that this was better than considering risk factors at baseline and was just as good as considering risk factors after 6 months of treatment.
Thank you, Sean, for summarizing the main results. In summary, we found that with cyclosporin or rituximab treatment, the best predictors of a later response to treatment were the changes in PLA2R levels, plus the changes in serum albumin after 3 months of treatment. This has a distinct advantage compared to our current management strategy of waiting for 6 months to assess the likelihood of response.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.